So the PACIFIC trial is a fundamental trial for the treatment of locally advanced non-small cell lung cancer, because we have to think that for the last 20 years we had nothing, because we had just the treatment strategies to go with chemotherapy and then to radiotherapy, to go with the concurrent chemoradiotherapy. But all the trials were not conclusive, and there were just 30% of patients still alive after a certain period. So the use of durvalumab after the chemoradiation is really important, is really practice changing, although we have the results only on the progression-free survival, which corresponds to an increase of about 11 months, which is quite a huge improvement. We do not have still the results on the overall survival, which is another important information to be achieved. But 11 months of progression-free survival, in my opinion, is quite a large improvement. So in my opinion, for all the patients who received concurrent chemoradiation, durvalumab must be offered for the treatment of this kind of patients. However, in the PACIFIC, there are still some questions that must be still answered, because in the PACIFIC, only patients who received concurrent chemoradiation could receive durvalumab. And we know that sometimes you decide to go with the sequential treatment and not with the concurrent chemoradiation. So there are still some areas that must be answered. For example, for the sequential is one of them. And also, for example, another point, a very important point, is the toxicity, because the patients included in the PACIFIC were patients with very low-grade toxicity from the radiotherapy. And in fact, the number of patients with the pneumonitis after chemoradiation and after durvalumab was very low. But the majority of patients after chemoradiation have a grade 2 or grade 3 pneumonitis. So we have no ideas if we treat this kind of patients with durvalumab, if we have an increase of pneumonitis. So I think that it is a very important breakthrough, because I think that from that point, the treatment of non-small cell lung cancer, non-operable non-small cell lung cancer, has totally changed. And I think that also that in the multidisciplinary team, sometimes if we are not sure if to go with the operation or to go with chemoradiation, now we have a new possibility of treating this kind of patients that can be sometimes can be important to decide to go with chemoradiation and not to go with the operation, because you have more chances to have a progression-free survival quite good. And what it is also important is that the results of the PACIFIC showed that there is not a very increased toxicity of chemoradiation if you administer durvalumab. So you have a quite safe regimen for this kind of patients after a treatment with curative intent. So the goal is try to cure a huge number of patients. So we could enroll patients within the PACIFIC trial. The PACIFIC trial was a double-blind, double-dummy trial, so we were not aware if the patient was receiving durvalumab or the placebo. But this was also important because we were not able to differentiate the patients receiving placebo or the drug, which means that there is not a huge difference between the placebo and the drug. Now we started with the drug after the chemoradiotherapy. We have the possibility to have the drug in Italy after chemoradiation. And what I can say is that what we saw also in the PACIFIC trial is true also in the clinical practice, because we do not observe an increase of toxicity in the treatment of this kind of patients. They are still on treatment, so I can't tell you if they will survive to the cancer, but what I can tell you is that the toxicity profile is quite manageable.
Based on the PACIFIC data, we all imagine that immunotherapy will enter the questions and the game of surgical early disease, right? Because if you have such a good outcome, an impressive outcome after radiochemotherapy, it probably means that you can act on survival by adding immunotherapy to the current multimodality treatment, and you can improve survival. That's why there are many ongoing trials at the time being. Also in resectable patients after or before surgery. When you speak about before, it's neoadjuvant immunotherapy. We have a small trial from the US using nivolumab, giving only 2 cycles of nivolumab, already showing that by doing that, you observe an incredible number of patients with pathological response. So really faster than you would observe in late disease, in advanced disease. With 2 cycles, when you resect the tumor, you already see a major effect on the tumor. Really telling you that this early disease might be different from late stage, right? It might be that the immune system is more, I would say, conserved or preserved, more active. Maybe the disease biology itself is easier to present to the immune system, but there's something there which makes probably immunotherapy even more promising in this early disease setting. So now there are some trials, I would not say many, but some trials trying to give neoadjuvant immunotherapy or neoadjuvant immuno and chemotherapy kind of intricated in this neoadjuvant phase. But of course, you also have we know this from breast cancer, the classical adjuvant trials where you randomize thousands of patients into chemo, standard of care chemo, versus chemo plus immunotherapy in the adjuvant setting. Very often you give first the chemo and then you give some immunotherapy for a longer period of time of 1 or 2 years. Of course, with an endpoint of progression-free survival, but what we would like to see, that you cure more patients, right? But this trial will take a long time to read. Adjuvant trials, of course, take a long time to read. But this is a very important question, and I think we might achieve there, for the first time, a real way of improving our survival rates in lung cancer, which is still not good even if you use surgery. In the PACIFIC trial, as far as I understood, I was not an investigator in this trial, reason why I could write the editorial. As far as I understood, the aim of this trial was to try to start as soon as possible the durvalumab. So it was to complete the radiochemo, and in the 2 weeks after the radiochemo, to start the durvalumab. However, in most of the centers, and also because the patient was suffering from some side effect from radiochemo, fatigue, swallowing problems, a cough, and so on, it was very often not feasible to start immediately durvalumab. So some patients did follow this scheme, but the accrual was not very satisfactory because lots of patients were lost from the strategy because of this short time frame of 2 weeks. The trial allowed up to 42 days afterwards in an amendment. So some patients had 2 weeks, but some had up to 6 weeks after the radiochemotherapy. So basically, the evidence that it's good to do so is based on a 42 days time frame at maximum. But what is interesting, and there is in the supplementary material, if I'm right, the comparison of the patients treated early with durvalumab or treated in the second step after the amendment with the 42 days. And it's interesting to see, of course, it's exploratory, but the benefit is higher in patients having the durvalumab as close as possible to the end of radiochemotherapy. Probably meaning that this vaccination process, that you can mount an immune response, is stronger if you really have the cell death and the radiotherapy happening a short time before you give immunotherapy. Some kind of multimodality treatment in time as close as possible one to the other one. So to date, I would say for a patient, if you can start immediately, start immediately. If your patient has remaining side effects, toxicity grade 2 or grade 3, even grade 1 for pneumonitis, then you should wait until this toxicity resolves. But if it's not the case, start as soon as possible. And theoretically, the window is 42 days. So that's where we are today, but this will be refined probably also in the future through other clinical trials.
So durvalumab is evaluated in several settings now, starting from the advanced lines with the Atlantic trial and the Arctic trial, where it is in combination with the anti-CTLA-4. It is investigated also in first-line setting with 2 important trials, which are the Poseidon trial using the combination of chemotherapy plus the durvalumab and plus or minus also tremelimumab. And there is also the MYSTIC trial, which is investigating the combination of tremelimumab, the anti-CTLA-4, plus the durvalumab again. There is also a trial in the adjuvant setting, so I think that durvalumab has been investigated everywhere.